So the topic of discussion today is quality of life after neck dissection. A quick search on PubMed on number of publications following neck dissection. We can see that uh, on the y-axis, the number of publications on neck dissection is in thousands every year. But once we add number of publications for quality of life and neck dissection on the y-axis, the number of publications are quite less than 10%, that is around 60 to 70 each year, which talks about quality of life after neck dissection. So it's still an area where we are evolving, and this needs definitely further research to actually put down parameters for assessment of quality of life. How do you perceive quality of life? It's an individual's perception of their position in life in the context of culture and value systems in which they live and in relation to their goals, standards, and concerns. So, what is important to understand is quality of life for every person is different. It's their own individual perception. It is the life they are living, the surrounding environment, their cultural differences. So, quality of life is different for each patient, and again, that is one of the parameters why it is so difficult to actually get a standardized measurement for disabilities or quality of life following any particular procedure. With regards to shoulder dysfunction after a neck dissection, the first paper was published in 1952 by Ewing and Martin to report resection of cranial nerve 11 with radical neck dissection resulted in significant shoulder impairment, including pain, reduction in strength, and range of motion. This was followed by another paper in 1961 by Nahum and Marmore, which reported that shoulder impairment after radical neck dissection is characterized by shoulder droop, winging of scapula, inability to strut, and dull non-localizing pain that was exacerbated by movement, particularly the shoulder abduction. These are the two quotes which is normally written in most of the papers. However, they also quoted these two things. A high proportion of patients who are submitted to radical neck dissection continue without much difficulty to earn their living, and operation is certainly compatible with active and independent life even in the elderly. So they suggested that one should not never hesitate to advocate radical neck dissection in removal of cancer in this area. Obviously, we have evolved from radical neck dissection to selective neck dissection and to central lymph node biopsy at this stage. So, what are the main causes for shoulder dysfunction following a neck dissection? Obviously, one of the major causes is injury to the spinal accessory nerve or a complete transaction to the nerve. Injury can be in the form of thermal injury by electrocautery, traction injury, that's a traction of the nerve during neck dissection, and one of the major causes which I feel is devascularization of the nerve. This happens while dissecting level 2B and level 5 lymph nodes, where we have to lift sometimes the nerve to clear all the soft tissue at level 5. Also, injury to the cervical plexus has shown some impairment in shoulder dysfunction because of the nerve supplying scapulohumeral girdle. These are the muscles like rhomboids, levator scapulae, screening muscle causing weakness at the shoulder joint. There are secondary craniohumeral stiffness resulting from postoperative forced immobility also can contribute to shoulder dysfunction. Coming to the last point, what they have suggested is that because of the sedentary lifestyle after the surgery, there is something called as adhesive capsulitis of the shoulder joint, and once this happens, it is very difficult to have a full recovery from shoulder dysfunction, even after having adequate rehabilitation following neck dissection. So we have gone through the causes, the available literature. So what about the assessment following neck dissection? So assessment can be in the form of active and passive movements of shoulder joint. We can also do something called as geniometric evaluation. That includes the symmetry of the shoulder joint, the symmetrical movement on both sides, palpatory examination of the shoulder joint, and we can do EMG studies on the muscles around the shoulder joints to see what is the trend of it. And there are many questionnaires. Unfortunately, the number of questionnaires are pretty high. which is one of the other problems why there is no uniformity in describing the quality of life following a neck dissection. One of the most commonly used is University of Washington Quality of Life Questionnaire, because it does have few questions which are specific to neck. Other questionnaire like Neck Dissection Impairment Index and Shoulder Pain and Disability Index are the two other most commonly used quality of life questionnaire following a neck dissection. So what are the components of shoulder syndrome or shoulder dysfunction following spinal accessory nerve injury? Pain, drooping of shoulder, inability to abduct the arm about 90, because that's a function which is mainly taken up by the trapezius muscle. 0 to 90 is by deltoid, which can be managed. Decreased flexion of the arm, forward rotation of the scapula making acromion process more prominent, and also the medial edge of the scapula more prominent, which is swinging of scapula. Sternoclavicular joint subluxation and glenohumeral joint capsulitis and fibrosis in severe cases as discussed because of the immobility of the patients following surgery. So we need to go on point basis. We will consider pain, we will consider disability, we will consider EMG studies outcome in future slides. Coming to the pain, it is one of the most common complaint after radical neck dissection, and there is again variability among various studies, but they all mention that requiring daily analgesia is not commonly seen in these patients. The incidence of pain is reported as high as 70%, and it can go as high as 77% between 1 to 6 months post-surgery. And after 6 months, when the recovery happens, still the incidence can be as high as 30%. If it is very important at 6 months, if the pain is still persistent, one needs to rule out recurrence as well before saying that the spinal accessory nerve traction or injury is the cause of it. So this is one of the studies which is looking at pain, quality of life, and spinal accessory nerve status after neck dissection. It had 397 patients treated for head and neck cancer, and they had completed quality of life surveys. The questionnaire used was head and neck quality of life and SF12, which is 12-point questionnaire for general and psychological health of the patient. The main outcome was pain and headache for this study. They had 22 patients among the 397 patients who had not had neck dissection. 46 had neck dissection with cranial nerve 11, that is spinal accessory nerve resected, and 129 patients who had neck dissection with cranial nerve 11 preserved. 69 spared level 5 and 61 included level 5. They found that with cranial nerve preservation, there was better pain score, less shoulder and neck pain, less frequent use of pain medication. And when level 5 was not dissected, again there was better pain and eating scores, less shoulder and neck pain, and fewer physical problems. So they concluded that better quality of life with cranial nerve 11 preservation and when level 5 dissection was avoided. Now, I was talking about the variability in the outcome. So these are the initial 13 papers which was published regarding shoulder disability following neck dissection. And you can look at the measurement they used. They've used their own, most of the studies have used their own questionnaires to actually look at the disabilities rather than having a standardized questionnaire to look at these disabilities. There are many more papers, obviously. The recent ones have been more better in terms of using a standardized questionnaire, but because there are so many questionnaires, again, compiling them and giving up a compiled data is very difficult. Again, the outcome measured is varied from strength to range of movement, and also it is important that at what time frame does the assessment happen. So if the assessment happened at 5 years or 3 months, so if you look at all these studies, they have variability in the time frame, in the outcome, and also the mode of measurement. And obviously, these studies are retrospective, some are cross-sectional, some are prospective. So because of this heterogeneity, if you open up 10 papers, you will definitely get different values in terms of impairment from each paper. So again, Some studies focused on symptoms, some on range of motion, and other evaluated activity limitations. So these activity limitations is basically wearing a shirt, buttoning, using buttons on the shirt, and using comb to comb your. So these are the major disabilities which patients complain of after shoulder impairment following a modified radical or radical neck dissection. So if you look at these other four major papers, one of the papers have mentioned disability in the range of 40% after modified radical neck dissection. Other papers have reported 28% of the patient experienced long-term pain. But Guldiken actually reported minimal disabilities following neck dissection impairment index post-surgery. And Carr et al. Actually said minimal upper limb dysfunction after selective neck dissection. So their inclusion criteria, assessment, everything was different, and the outcome is different as well. From pain, we move on to the electromyographic findings with selective neck dissection. This study is quite interesting because it looked at the impact of preservation and excision of cervical nerve, that is C2 to C4, during a neck dissection, especially in cases of selective neck dissection. So these are the patients where spinal necessary nerve was preserved anyways, but whether the resection of cervical plexus was done or not during the neck dissection. So these are 54 patients with 70 selective neck dissection, and electromyography was used, and the outcome was basically labeled in a 5-point scale, where 1 is total denervation and 5 is normal muscle function. And the muscle assessed in this study was upper trapezius muscle. So what they found was the average EMG score was 1.7, which is quite poor, and only 5% of the cases had a normal pattern EMG after neck dissection, and more than 50% of the cases had total denervation. So there was significant difference between the group with cervical plexus excised and preserved. So it is important that during neck dissection, we try to preserve the cervical plexus as well, along with the spinal necessary nerve. So they concluded that upper trapezius denervation is likely caused by external injury to the spinal necessary nerve, despite being spared due to traction during surgery. An excision of C2 P4 rami of cervical plexus leads to further damage in shoulder dysfunction, and preservation of cervical nerve is crucial to avoid upper trapezius denervation. These are the other studies which talks about the electrophysiological finding, and they have shown that the electrophysiological assessment was significantly decreased in amplitude and scores in radical neck dissection as compared to modified radical neck dissection, where 11th nerve was preserved. Another study showed functional neck dissection had quite a good normal score as compared to radical neck dissection. Level 5 again, in pain, level 5 neck dissection was significantly worse. But for EMG studies, it is not significantly worse, but worse as compared to cases where level 5 neck dissection was not done. These are the similar findings for electrophysiology. Coming to employment, it is important to note that quite a few patients after neck dissection or head and neck surgery have to actually change their occupation, and it has been reported that more than 50% of the patients return to their usual occupation post-treatment, with similar unemployment rate observed in patients between whether you do modified radical neck dissection and radical neck dissection. So I think it is again very difficult to assess, because we are looking at occupation which we are not aware of, and whether that how much important shoulder movement is in their occupation is quite critical in assessing while interpreting the result of the study. Any patient who is lifting heavy weight will obviously have more problems, and they have to change their occupation as compared to an office desk job who can easily do their work on a table or a computer. So we are now looking at the function of the shoulder joint at the range of movement. So we looked at the pain, we looked at the electromyography finding, and we are now looking at the shoulder movement. So this study is quite interesting again, because it has a very small sample size of 66 patients, but it's a prospective study, and it is looking at it's looking at the function of shoulder at different time frame, that is at 1 month, 3 months, 6 months, 9 months, and 12 months post surgery. It is looking at active shoulder abduction angles and shoulder specific quality of life questionnaire, which is Western Ontario Rotatory Cuff Questionnaire. So in this case, what they found was maximum active shoulder abduction angle was poor, worst actually at post-operative first month. But as you go along, at post-operative 3 months, post-operative 6 months, 9 months, and 12 months, there was significant improvement in shoulder abduction as compared to post-operative first month. So normal abduction pre-op in these patients was seen at 165 degrees. So we also looked at active shoulder abduction with cutoff angle of 150 degree. So they have looked into pre-op where 96% of the cases could have a shoulder abduction of more than 150 degree, but at post-operative first month, only 17.6% of the patients could actually have a shoulder abduction of more than 150 degree. This gradually improved, but statistically significant improvement was seen actually at 6 months, 9 months, and 12 months as compared to first month. Similarly, in terms of the questionnaire score, it was worse in post-operative day 1 and improved significantly at post-operative 6 month, 9 month, and 12 month. So we understand that the quality of life and the shoulder abduction is worse in the first month period, but with rehabilitation and proper treatment, probably we can see improvement in shoulder movement as well as the quality of life questionnaire. The same study also looked at whether level 2 being positive, level 5 neck dissection, head neck irradiation, or post-op radiotherapy affects the function of the shoulder. What they found is with level 5 dissection, there's definitely impairment in shoulder function, which was statistically significant at 6 months and 9 months. This was true also for head and neck irradiation. With regards to post-operative radiotherapy, the impairment was more seen at 3 months and 6 months, which then gradually improved at 9 months and 12 months. Interestingly, level 2 positive lymph node did not have any significant impairment on the shoulder dysfunction. So, initial shoulder dysfunction declines after surgery, but then often improves at 6 months and 1 year. Despite similar rates of early impairment, long-term outcomes show that radical dissection patients have significantly worse range of movement, strength, pain, and activity limitations compared to who underwent modified radical neck dissection. So it's quite clear that obviously sacrificing cranial nerve 11 have significant impairment not only electrophysiologically but also with regards to the movement at the shoulder joint. Now, coming to level 1B preservation, whether this improves shoulder function and quality of life. We saw in the previous study that they didn't found any improvement with level 2B. They have actually looked at positivity of level 2. In this case, they have looked at preservation of level 2B, which is more appropriate, I think, because in that study, again, we don't know how many patients underwent level 2B or not. So, this is again a prospective study. Patient undergoing neck dissection were divided into 3 groups. First group where level 2B was preserved, second group where level 2B was dissected, and third group where level 2B and 5 was dissected. The post-operative shoulder function and quality of life was assessed. So we had in group 1 around 9 patients, group 2 16 patients who underwent level 2B dissection, and group 3 10 patients who underwent level 2B and 5 level dissection. So what they found was, as expected, the patients who had level 2B preservation had less shoulder dysfunction in the early post-operative period, and quality of life was better preserved in group 1 during the early post-operative period as well. So it is expected that when we preserve level 2B, we are giving less traction to the spinal accessory nerve. We are obviously giving higher chances of injury. So preserving level 2B is quite a good idea if you want to preserve the shoulder function. And right now we do have quite a good meta-analysis which says that the incidence of level 2B metastasis is as low as 1 to 2% in a clinically N0 neck. So in those cases, it is advisable to preserve level 2B. So what can we do to minimize the incidence of shoulder dysfunction after neck dissection? So first, we can consider a selective neck dissection rather than a comprehensive neck dissection in N0 neck. We have burned that bridge, and we are at that stage where we most probably do selective neck dissection in most of the N0 neck. We should avoid radical neck dissection in an N plus neck. Again, we have burned that bridge as well. We always normally do a modified radical neck dissection in an N plus neck. In fact, avoiding level 5 in N plus neck is also an emerging evidence, and that can be considered in oral cavity because the probability of recurrence in level 5 after an oral cavity surgery is very, very low. Minimal handling of nerve to avoid traction injury, and avoid thermal damage by using bipolar cautery. So dissemination of energy around the monopolar is in the range of 3 to 4 millimeter, and for bipolar is between 1 to 2 millimeters. So obviously that depends on the voltage used, but this is an average. So if you use bipolar around the spinal axillary nerve, the chances of injury or traction injury or thermal damage is less. Using another option is using LigaSure as well, which is quite convenient in terms of dissection, and it's pretty quick in that region as well, which can help in preserving the shoulder function. So as discussed before, level 2B and level 5 should be addressed in appropriate patients to minimize shoulder dysfunction after a neck dissection. So obviously now we have looked into the pain, electrophysiology, the shoulder abduction range. We have looked into the factors which actually can cause higher shoulder dysfunction, and we have found that level 2B, level 5 dissection, sacrificing spinal axillary nerve, and postoperative radiotherapy are one of the significant factors which can impact shoulder function after the surgery. So we're looking at rehabilitation now after the surgery, and rehabilitation is in the form of mainly physiotherapy. But what they have found in this study, this is one of the meta-analysis which actually looks at different rehabilitation intervention affecting shoulder dysfunction in patients with head and neck cancer. What they suggested was progressive resistance training. So progressive resistance training is a training where a dynamic weight is given to the patient depending on how he is progressing, has shown better outcome with regards to pain and dysfunction, with a mean difference of 5 as compared to the conventional physiotherapy, which is mainly a static physiotherapy, where the resistance given is quite same throughout the treatment period. Also, they found better abduction and flexion and quality of life with progressive resistance training as compared to conventional training. So, obviously, the evidence at this stage, because we don't have much randomized control trial, is moderate certainty. But they say it's definitely better than conventional treatment for improving pain and dysfunction. This meta-analysis at 214 patients, and the mean difference, as we discussed, was 5. Acupuncture was also found to be a good alternative and more effective than conventional treatment. But again, because of the outcome measured and the uncertainty of the data, a pool analysis was not performed in this meta-analysis. So finally, they concluded that progressive resistance training is effective for improving shoulder pain and dysfunction after a neck dissection. But obviously, with regards to acupuncture, further high-quality studies are needed to confirm its effectiveness. So we are coming to treatment. We have looked at rehabilitation. So early postoperative shoulder physiotherapy, including active and passive movement, is important. Progressive resistance exercise training is found to be more effective than routine physiotherapy. In advanced cases where there is muscular atrophy, capsular adhesions, adhesive capsulitis, as discussed before, no treatment is found to be that effective because physiotherapy might not be able to overcome this. Is surgery an option in those cases? Not much studies. I think the surgery is an absolute at this present day and age. What can be considered is a muscle transfer where trapezius is not working, so we can transfer levator, scapula, and rhomboid muscle and reattach to the scapula to help it stabilize and improve the shoulder dysfunction. But I've never seen it being done, and probably it is not done nowadays because I think it's also this other factors which are contributing to the shoulder dysfunction, which we might not be able to correct, and thus the results of the surgery might not be very good. So, in summary, shoulder impairment is common after neck dissection, with selective neck dissection showing better long-term outcomes, especially when level 5, and I would add level 2B if not addressed. Electromyography findings support greater nerve damage and slower recovery in radical neck dissection patient. Despite initial impairment, recovery is possible within a year, although severe cases can significantly impact quality of life and employment. So, we've looked into the damage of the spinal accessory nerve leading to shoulder dysfunction and quality of life impact after a neck dissection. I'm just touching down on one more aspect of lymphedema after neck dissection, whether that causes significant symptom, functional status, or life impairment. So this is a small, again, the literature is very, very limited in this topic as well. We had only 103 patients and the assessment was done 3 months post-treatment. And they've actually labeled internal lymphedema and external lymphedema. Internal lymphedema, they've assessed using a scope, and they've used basically FACT head and neck questionnaire to look at the outcomes of quality of life. They've classified the external lymphedema with something called as Patterson's scale, which is 0 to 3, and 0 is good and 3 is worse. And what they found was the external lymphedema correlated with decreased neck left and right rotation. So I think it's very important when the patient comes in the clinic complaining of shoulder dysfunction, we address these factors as well. And external massage, compression bandage, I have seen it works wonder in my clinic, whether the lymphedema clinic in my place is amazing, but it really helps the patient in terms of edema and their external appearance and their confidence to go out in a social gathering. And they also found that internal lymphedema, which was classified based on Foley scale, again classified as 0 to 3, 3 being the worst and 0 being very good, as found to be linked with impaired hearing and associated with decreased quality of life based on FACT head and neck questionnaire. So, lymphedema also significantly impacts symptom burden, functional status, and overall quality of life in patients following head and neck cancer treatment, and it is important to address them after the surgery. So, thank you again for inviting me for this talk. Thank you.
Thank you, Dr. Manish. It's a very lucid presentation of an important aspect of the management of head and neck cancers, which has been neglected by most of us in the initial part of. We will be focusing more on the surgical clearance, and now of late, only last maybe 15-20 years, we have been thinking more about all this. Any questions?
Sir, I have a question. So, to assess shoulder dysfunction, there is this NDI, neck dissection impairment index and constant scale. Do you have any take on what?
I can't hear anything from the audience, unfortunately.
Sir, is it audible?
Yeah, but it's showing mute on the podium, so I'm not sure, but I can hear better.
Yeah. Okay. Sir, to assess the shoulder dysfunction following neck dissection, there is neck dissection impairment index and constant score. So, what do you feel is an ideal score that would be able to assess the shoulder function following neck dissection?
So I think both questionnaire has its own benefit. If you look at the most commonly used, it's mainly the health impairment index, which is used more commonly as compared to the constant score. And the range of movement is, I think, is more looked into the impairment index as compared to the constant score, and constant score is more targeted towards the pain. So I think the problem is there's not a single questionnaire which kind of gives us a very good overall outcome. And that's the problem at this stage. We need a proper score questionnaire which kind of looks into all the parameters and which can give us a better outcome. So it is more uniform whenever a study is done in any part of the world or at any center.
Thank you, sir.
Can you hear me?
Sir, is it audible? Hello? I mean, from the audience, there is a question.
Yeah.
Can you hear me?
So you can tell the question so that I can convey it.
This is a comment to convey my regards to all the nurses in head and neck and maxillofacial cluster
So he's conveying the regards to all the nurses in maxillofacial unit in the UK.
and head and neck in Leicester.
And head and neck and
Thank you.
Yeah.
Mr. Avery as well.
And Mr. Avery as well.
Oh, okay. Thank you. Yeah, he works with me.
Thank you, sir.
Thank you, Dr.
Yeah.
Manish,
Thank
for being a part of this. We appreciate it.
Thank you. Yeah.